Hello, I'm Stephanie Baum, Director of Special Projects with MedCity News, and welcome to our panel discussion on how health systems tackle burnout and mental health of frontline workers. Through pictures and tweets, the extreme pressure that frontline health workers endured was laid bare during 2020. But burnout is not just the cause of a once-in-a-century pandemic. How are health systems addressing behavioral health issues and supporting mental health of doctors, nurses, and others? This session will be moderated by Dabrow Woods, Chief Nurse, Health, Learning, Research, and Practice with Wolters Kluwer, a global company that produces and publishes information for healthcare professionals in education, practice, and research. A nurse for over 35 years and a board-certified nurse practitioner since 1998, and is an acute care, critical care nurse practitioner for Penn Medicine, Chester County Hospital. She also serves as clinical adjunct faculty for the College of Nursing and Health Professions for Drexel University in Philadelphia. She received a bachelor's degree from Westchester University, a master's degree from LaSalle University, a postmaster's certificate from Drexel University, and a Doctor of Nursing practice degree from Texas Christian University. Also on the panel is Peter Buecker, the Chief Medical Officer of BehaVR Health, a company that aims to help people achieve lasting behavior change by leveraging the power of virtual reality technology. Peter has been in medical practice as an orthopedic surgeon since 2005. For 2 years, he owned and operated Wellness 360, a center dedicated to wellness of body, mind, and spirit, using holistic health practices such as yoga, massage, meditation, and health coaching. He is currently completing a PhD in mind-body medicine at Saybrook University. He is the author of No Magic Pill, Be Happier and Healthier Now, Just as You Are. Also on the panel is Leslie Kelly, a nurse scientist with CommonSpirit Health. She has a career in examining nurse and patient outcomes associated with clinician well-being. Her dynamic portfolio of funded research includes studies on nurse burnout, the healthcare work environment, and leadership behaviors. She is passionate about translating research and educating future clinicians on well-being through implementing strategies to decrease the consequential effects of burnout. Aside from her role as a nurse scientist at CommonSpirit Health, she is an associate clinical professor at Arizona State University, Edson College of Nursing and Health Innovation. Leslie obtained her BSN and PhD from the University of Arizona College of Nursing and her postdoctoral fellowship from the University of Pennsylvania Center for Health Outcomes and Policy Research. We also have on the panel Felicia Speed, Vice President of Social Work Services for Fresenius Medical Care North America, the nation's leading network of dialysis facilities. She currently provides oversight and guidance to social workers across the country and has been working as a dialysis social worker in various capacities for almost 20 years. After obtaining her bachelor's in social work from Winthrop University and master's in social work from the University of Georgia in 1999, she accepted a position as a social worker for Anderson Dialysis Clinic. Since that time, she has dedicated her career to addressing psychosocial barriers among dialysis patients with kidney failure by improving social work competency. Felicia also has been successful in collaborating with the Centers for Medicare and Medicaid Services to improve patient-provider relationships. And now over to you, Anne.
Thank you so much, MedCity, for putting this panel of great speakers together. So we're going to kick it right off, talking about COVID, its effects, and how we can actually support our workforce. So this first question is going to be posed to Leslie and Felicia. What did your healthcare system experience with the COVID-19 pandemic? So Felicia, we'll go to you first.
Oh, okay, yes. So thanks for having me join this important discussion. So for those who are familiar with our company, Fresenius Medical Care North America, we are one of the nation's leading providers of kidney care products and services. And in my role as the VP of Social Work Services, I saw firsthand how we were able to quickly prepare and mobilize against COVID-19. So our team is responsible for providing treatment to probably more than 200,000 patients on dialysis who are much more at a higher risk of COVID-19, and they have more experience to severe complications or hospitalizations because of that. So it makes them a very vulnerable population. So to protect our patients and our staff, Fresenius, we took rapid proactive steps to minimize the spread of COVID-19 with our patients by rolling out a series of initiatives that exceeded the CDC guidelines. This included screening, testing, masking, and PPE in early March. And then we also set up isolation centers where we placed our patients that were positive for COVID-19 to be able to keep them separate from our regular dialysis population. We really wanted to protect our patients and also reduce the burden on hospital emergency room admissions. So we also established a telehealth system in only a few weeks to minimize the amount of people required to enter our dialysis centers as well.
Great, thanks, Felicia. Now I'm going to turn it over to Leslie. Same question, just briefly, what did your healthcare system experience with the COVID-19 pandemic?
Yeah, I echo Felicia's sentiment. Thank you very much for this. And I think, when you think about acute care, it's been pretty well documented about the experiences. And when you think about the CommonSpirit healthcare system, we're a very large acute care system. So we actually had variation among our divisions because of the different regions that they were in, right? So some areas were really hit quick with less time to act, less time to prep, and they really jumped in right away with those quick decision making and response times to the surges that were happening. Whereas other parts of the country were really having long anticipatory stages where, our workforce really had some fear setting in about what was coming. But eventually, everyone had a surge. And what you see is that, what we've seen documented, it really was an unknown virus. And just as Felicia was saying, we really had to learn how to treat, and we were responding with CDC guidelines and going above and beyond to those practice settings where we were learning how to treat patients and coming up with innovations to respond to that. You know as well that there were those initial shortages of PPE. We had adjustments and changes to our workload. And these long periods where our workforce was in PPE, less breaks, the nature of COVID care is just really different than what we were essentially used to. And then don't forget, we had other areas that were experienced different types of practice. So furloughs or reassignments, new areas of practice. But in the end, we really had teams coming together. We had our community supporting us. We saw really shining examples of leadership and innovation that have really been exemplars in our system.
Well, when everybody was initially fighting COVID, we didn't know a lot about it. So there was a lot of what we all call the fear factor. So many of our frontline workers really worried about safety from the perspective, as you said, of not having enough personal protective equipment, overall resources, and even skilled staff to take care of these patients. So I'm going to start with you, Leslie. So what did your organization do to help the frontline workers feel safe and kind of eliminate that whole fear factor? And if you could just keep it brief, please.
Absolutely. I think like many places across the country, we stood up a COVID-19 command center, a task force. And the real key here was communication. As soon as we learned something, the key is to get it out right away. So daily communication. The other thing that was really important was staffing and retraining, learning, mobilizing those staffs to area of high needs. The other thing that CommonSpirit excelled in was virtual care. So supporting staff. When we couldn't put actual staff there, we stood up virtual care to help support in the virtual realm. And then that resources, PPE, helping in those arenas and getting it as fast and quickly as we could to the staff. We really tried to hit, when you think about Maslow's basic hierarchy of needs, we're trying hard to get to those basic needs that were there to support that fear need. And then I know we're going to talk about the well-being aspect as well. And that was really important to address. First, those basic infection control safety needs, and then get to the well-being.
Absolutely, Leslie. Thank you for your response. Now I'm going to go over to Felicia. So Felicia, you have all these dialysis centers. I'm sure that your staff felt that fear factor. So what did you do to help your organization, the workers, feel safe so they could combat that fear factor and really get down to the heart of what they need to do was to take care of these patients? What did your organization do?
So I definitely agree with Leslie. Communication was the key. because we know that everyone was hearing so many things from several different, news media, social media. There were so many things that perpetuated a lot of fear. We had that tickler, when you looked at various news stations. And so our priority at FMCNA was and remains to protect our employees and to best serve our patients. So as a global company, we had been monitoring the situation even before January. So when we first mobilized our clinics to order appropriate protective and safety materials, we began to mobilize it early. And in the end, we always maintain our supply of PPE, which was absolutely critical. I am a firm believer of Maslow's hierarchy of needs. And so, yes, it was very important that we took care of those basics, and having weekly calls, having daily calls, making sure we had recordings of that. So even our frontline workers that couldn't listen to those calls at that moment, we had the employee hub to go, had various ways to be able to communicate with them, even outside of work, so they could keep up what was going on. Because the stress of managing this new way of working was real, and our caregivers could not work from home. They couldn't work. Dialysis is a life-sustaining treatment. Patients have to have it. People have to have it. So making sure we had new policies, procedures, and adequate PPE was very important, and allowing our frontline team to focus on caring for patients. So we wanted to provide them every resource we could. So while they're taking care of the patients, we're taking care of them.
Great. So as the pandemic surged, many of our frontline workers started to feel really overwhelmed, exhausted, burned out. They're experiencing moral distress and injury. So I'm going to pose this question to Peter. So how do you recognize those people who are experiencing these issues? And what efforts do you put in place to recognize the frontline workers who are experiencing these feelings? How do you point them out? How do you identify who they are?
Yeah, it's a great question, and thanks for having me as part of the discussion. For us, we are a digital healthcare solutions company, and so a lot of our efforts are just based on listening to what our clinical partners are saying. So we really want to hear. We simply listen to heard the voices of the healthcare workers that were saying, "Hey, we need something. We need help." When we look at burnout and the factors of burnout, for instance, we know that the major ones are exhaustion, physical and emotional exhaustion, of feeling ineffective in your job, of feeling disconnected, starting to be overrun on that compassion side, and then all the feelings of guilt and that may come with that for healthcare and frontline workers. So I think it's easy to see and safe to say that workers were experiencing all of these things on overload, and to Leslie's point, something that very overwhelmed the system very quickly and unexpectedly. And so for us, simply, our model is that we work with clinical partners in their domains of expertise. And so for us, it was very simple. Like, we're working with these partners who are saying, "Hey, I know we're working on this, but our people need help now. What do you have?" So that's it. Just seeing what's happening and listening.
I think that art of listening, right? Sometimes in the heat of the moment, it gets overlooked, and that's the most important thing. So I'm going to send it over to Leslie. Leslie, I'm sure that your workforce was feeling all those things: exhausted, burned out, having that moral distress and injury. How do you really recognize those people who are experiencing these issues?
Sure. Yeah. I mean, so this has been my work for over a decade before the COVID-19 pandemic even hit. So when we saw the coronavirus infection issue happening, there was actually already evidence coming out of Wuhan that this was a psychological distress issue as well. So in the CommonSpirit industry, we formed a group, a multidisciplinary group, saying this is going to be an issue for us from a workforce moral distress, burnout, safety issue as well. And our group said, we're very grateful that these resources are going to come and that our workforce is going to have support. but you can get overwhelmed with what's getting thrown at you from that perspective as well. And it's hard to understand what you should be paying attention to. I mean, just from even my perspective as a researcher, what am I supposed to listen to? Should I be doing mindfulness? Should I be looking at programs? How do I cut through the noise? So our group said, we're going to help our staff focus just on psychological first aid, because when you're in crisis and when you're dealing with the pandemic, the surge, you can't be looking at a long-term solution just yet. You need to focus on this short term. And so we helped our workforce by saying, focus on that psychological first aid, focus on getting yourself to a state where you can be safe. Again, Maslow's hierarchy of need. You can focus on getting yourself into a calmer adrenaline state, and you can get yourself to a place where you can get support if you need it. So trusted sources like Peter's group or VAP, or places where we could really cut through everything that was being thrown at them and streamline evidence-based resources to support them. So being out on the floors, rounding, on-site EAP, these resources that would help them, in the moment with identification. We're finally slowly starting to move into a stage where we can say, here's some longer-term support.
Great. It sounds like you guys were doing all the right thing at CommonSpirit. That's great. So Felicia, you're out there at a lot of your standalone centers. So I'm sure that your staff was really feeling overwhelmed, burned out, having that moral distress. How did you recognize these folks that were experiencing this feeling?
Really began to mobilize our social workers. Our social workers are in, we're required to have one in every facility in some capacity, even if they have multiple. So we really began to equip our social workers with the tools that they need and things to be able to observe. And just as Peter was talking about, the basic factors of burnout, we began to just educate on what burnout is. And one part of burnout is depersonalization, where you have this feeling of watching yourself from the outside. And a lot of that depersonalization can lead to compassion fatigue. So we really began to talk about that, and understanding that to have compassion fatigue, you first of all had to have compassion. So the fact that you had compassion means that at one point in your life, or at the beginning of this year, or the beginning of the end of 2019, you cared, you had compassion, you love people, you want to take care of people. So how can we get you back to that place? Well, first, like you said, we had to identify the signs. When they started to isolate, when they began to be very sarcastic, or, not wanting to talk to the patients or communicate with the patients, where you found that they just wanted just to get through the day. So when we found that they really wasn't present, then that's when we began to have huddles, like mental health huddles, just to be able to have the discussion, to talk about the loss, to talk about the grief, to talk about their frustration. So we began to mobilize that across the country, and we did find that to be extremely helpful.
That's great. Again, it sounds like your group is really doing the right things. So when we look at COVID, and especially with the first waves that we were seeing, the severity of illness and death was really overwhelming. I myself am a critical care nurse practitioner, and I saw the severity of illness like I've never seen it before. And seeing all the people who were dying despite what we did for them was really heartbreaking for us. So what do you think healthcare systems do to actually support the staff who are dealing with that whole idea of always having to take care of these very high acuity patients and death? So I'm going to ask Felicia first.
Thank you. So I think the first step is leadership it's important that they address the reality of the situation. There's no need to sugarcoat it. And I believe that's what we did when it came to COVID-19, as well as understanding the rate of burnout and openly within your own organization. Particularly in healthcare, there is like this pervasive care culture that can hide invisible threats and perpetuate lasting silent pain for people who just don't feel like they feel safe enough to communicate how they're really feeling, because there's this expectation that I have to be on And we're so used to being on, but we've always had breaks and now we don't, right? And so there's much more to be revealed about the long-term solutions that can address burnout in a compassionate, sustainable way. But if executives can help by creating a roadmap of solutions that validate burnout and customize the needs at every rank of experience, I don't think there's a cookie cutter. I don't think there's a one size that fits all. But the way we can do better with that is by individualizing the needs and looking for better ways to protect the mental well-being of all of our employees.
Excellent, excellent. So I'm going to turn it over to Leslie. So Leslie, high acuity patients, severity of illness like we've never seen it before, a lot of death at such a level that we never saw before. What did you do through CommonSpirit to really support the staff that were dealing with all of that?
Yeah, I mean, Felicia just really nailed it. So I think what we're talking about here is secondary traumatic stress, right? We've always dealt with this in our profession as clinicians. And sometimes I call it a byproduct of our caregiving. We're in this field because we're caring for others when they are in critical need or a time where there's a break in their health. We don't want them to have a break in their health, but we need to care for them during this time. And look at what COVID-19 did to that, right? This is something none of us expected, and it accelerated it and just, really put a huge amount on our caregiving workforce. So, we kept up with it the best we could, but our interventions for this are not as well developed as they should be in our healthcare workforce. So just as Felicia was talking about, we have to start by talking about it, right? Some places, some people, some individuals do better than others, but sometimes there's stigma around this, right? If my patient passes away, I need a break. I need to honor and acknowledge that patient. And there are different types of clinicians that say, okay, that happened, let's move on. Here's your next admission. Or, that was the right time for the patient. And even if that was a good passing and it was right for the patient, pre or post-COVID, right? Death can be a positive thing. It still can be hard for the clinician. And so we need interventions and opportunities in place to say, I need to acknowledge that. And that's why you see things like a post-code pause or an honor walk or activities that memorialize that event, that patient activity, that help do that for the caregiver to give a moment. This is really like that first basic step in supporting the staff. And there are definitely facilities and units and caregivers that are better doing that. But to get to that culture of well-being, we need to create that whole culture where everybody has the opportunity to do that. And then we do need that long-term support in this area because all individuals carry this differently, and leadership needs to understand that, this support needs to be individualized. So how I address this and how I carry this through my practice and my caregiving, I need to recognize that this is something that I need to be addressing long-term so that I can stay in this profession and provide good quality care through a long, healthy career.
Really good points. I think that I can tell you from my personal experience, when you see a lot of death over and over again, before, if there was like a code blue, we would always tell the staff, you did a great job, regardless of the outcome. And with COVID, because the death was coming so fast, a lot of times people forgot to do that. And I think that's a key thing. You have to stop and say, look, we did the best that we could. And this was the outcome, but we still did a good job caring for the patient. Absolutely. Peter, I'm going to turn it over to you. We're talking a lot about, the fact that clinicians everywhere, whether you're a physician, nurse, social worker, any clinician, we saw so much death and dying in those high acuity patients. How do we recognize the person who's in trouble with dealing with that?
Well, it's a great question, and I'm not sure there's a panacea response. However, I can say, my clinical background was as an orthopedic surgeon, but my specialty was oncology. So we dealt with high acuity patients, oftentimes terminal patients. routinely. And I think in healthcare in general, we have this ability, I think we have to have this ability to sort of compartmentalize these feelings, these deep emotions, this grief that we go through with our patients and with what we see. And I think, again, what we saw with COVID was just the massive scale of it is a huge problem. It's hard to compartmentalize, work through the feelings, kind of move through that, and then be able to take care of the next patient. As we in surgery always say, you're only ever as good as your last operation, right? And so if what we have is this constant stream of really sick and dying people, it can really, of course, weigh on not only on our emotional integrity, but also on our confidence. And I think the additional component that has been so prevalent through this period, and we haven't really given voice to just yet, is that the frontline workers are not only doing the job as frontline workers, they were often doing the job of family for these patients as well. And so kind of carrying that double burden of being the one holding the person's hand, comforting them, knowing they were dying, but trying to comfort them. And then, having to sometimes be the liaison with the family, or if there was no family, then they were it. And now they have to carry that sort of double burden into the next patient room. So I think kind of to what Felicia was expressing, and Leslie as well, is normalizing those feelings. Like, it's okay. This idea that we have to compartmentalize and be tough and not let it get to us and get to the next person. There's always more people to take care of. It's like, okay, that can work on a day-to-day basis when you're not completely inundated. Not that it's the healthiest way of going about things, but of course it's very common in the healthcare world, and you have to be able to do that to some degree. But normalizing, like, it's okay. We're all feeling this, and I think for us, one of the big priorities was realizing that while many hospitals made adjustments, there are certain mental health practitioners or chaplains that were available specifically to the healthcare workforce. One of the things that we're very aware of and is very central to our mission is we also realize that humans are not scalable. So this crisis for us really brought some things home to say, the things that we do, we need to make sure that we can offer meaningful interventions for people at scale, because we can't suddenly train and bring a whole new group of people in to take care of this massive load of trauma. Really is what we're dealing with on the front lines, this traumatic experiences for the healthcare workers. We can't suddenly, train a bunch more people, and those chaplains and those mental health care workers are also overloaded and need to be taken care of. So how do we, so for us, how do we do something that kind of comes in the middle there, takes care of the workers, helps offload those already overworked helping professionals that are helping the helpers, so to speak, and do that at scale. And so I think that's certainly not something that we or anyone have answered to this point, but certainly I think this crisis has given has brought real awareness to the fact that, scale is an issue. And we can talk generally about the rapidly accelerating rate of reported symptoms of anxiety, depression, all kinds of mental health exacerbations through the period of COVID generally, and then also focus that into the healthcare workers, because healthcare workers are, number one, not monolithic. Number two is before they're a nurse, a doctor, a PA, or whomever, they're humans, and
Right.
They go home to families and have real other human concerns like everyone else. And now we add this burden. So it's maybe an over answer to the question that you asked, but it's like I think it just speaks to the massive problem that we're discussing.
Absolutely agree. When we look at healthcare workers, many of them felt really unsafe. They're overworked, they're undervalued, and they're feeling burnout. And we know through research that these individuals will go on to leave their current place of employment, and worse, could go on to leave their profession, which is what we don't want to happen. So how do you recognize a person who's experiencing, say, situational anxiety, depression over what's going on, to someone who really has a big problem with that, with more generalized anxiety or more severe depression? How do you know? How do you know who's at the breaking point and who's, is really at risk for burnout? And I'm going to ask Peter, you first.
Yeah, thank you for that question. And that's one a very significant personal interest. I mean, I found myself in that position way pre-COVID, but just with the mounting demands and the changing aspects of the industry. But, you know, my brain is an orthopedic surgery brain, right? So I like things that sort of are practical and simple ways of thinking about things, so we can start looking for solutions. So I like that sort of definition of burnout that says, you know, this is a chronic stress condition that does not improve with things that normally would improve your stress. So having time off, you know, getting the help that you need, and the symptoms are still there. So the second that you walk back onto your unit and you walk to that first patient's bedside, it's like you never left. And I think being able to track that in people, of course, is hard if they're not opening up and talking about that. But I think if we can monitor their behaviors, you know, often we get very good at understanding what are coping behaviors and what are our normal caring behaviors. And I think it speaks to the hospital culture, the unit culture where they are, that the managers, like, you have to know who your people are. And I think we have to be paying attention and frankly, taking good care of one another in that way. So if I see someone who's exhausted, who's moody, who is down, who's not performing at the normal level, or maybe they're making some mistakes that they normally wouldn't make, maybe they're being chippy with coworkers where they normally wouldn't be chippy with coworkers. It simply is like, you know, no one really loves confrontation or feeling like you're going to create an uncomfortable situation for someone, but pulling that person aside and saying, you know, is everything okay? I know you've been under a lot of strain lately. You know, we're all hurting. This is difficult. Like, you know, how can we support you? I think there's this toughness mentality in healthcare that is awesome sometimes and really works against us at others. So I think just paying attention, knowing your workers, and being willing to call it out when you see it.
Great. I think that's a really good point. And I'm going to go over to Felicia, because being a social worker, this is right in your sweet spot. You know, I think what Peter said, you know, we're so good at caring for other people, we forget to look at ourselves or look at our colleagues. So how do you take a look at the staff, your colleagues working beside you, and see the person who's getting in trouble with anxiety, depression, and who may need an intervention?
So, you know, the question was talking about, you know, how do you know the difference between like situational anxiety? And when I look at that, that's like a response to a specific situation, like a job interview, giving a presentation, you know, a patient's blood pressure just dropped, or even like being on this panel today. So someone may have difficulty concentrating, they may have dry mouth, muscle tension, sweating, nervousness, but it's a very short period of time. To me, that's more of the situational stress, like in that moment, you know, where we may have a patient, you know, blood pressure bottom out, or we may have a bleeding, things like that. So that's situational in that moment, but you're able to see the person bounce back, right? So when I start to look for that burnout, that breaking point, is when I don't see them bouncing back, when I don't see their normal resiliency as a healthcare worker to be able to say, okay, I processed it, I know what happened, and I've moved on. But it's just, as Peter said, where they're still there, they're still in that moment. And so when you start to see that depersonalization, when you start to see where they're not just tired one day, but they have this emotional exhaustion where they're snapping at people and things of that nature. So what we did is we really started to have more group discussions, because we couldn't touch everybody. So we started to have, and we didn't have to take the people that's helping. I had to help take care of my social workers to make sure they were okay as they were giving. So I think it's just more of observation, communication, and with communication, you don't need to have a bunch of PowerPoint slides. You just need to listen.
Again, that art of listening keeps coming up. Really, really important point. And Felicia, I'm going to stick with you on this one, because I think it leads really well into the next point we want to cover, which is suicide. We've seen, and well, prior to COVID, we knew we had an issue with suicide among healthcare professionals. But with COVID, we're seeing it be more prevalent. So how do you recognize the person that you're working next to who's at risk for suicide?
Well, absolutely. We must do all that we can to protect our healthcare workers. And that starts at the top. So we should look for observable signs of depression, which can be coupled with anxiety. When you're noticing changes in behavior, changes in their personality, you know, unrelenting low mood, hopelessness, being very withdrawn where they used to be, wanting to be around everybody, and now they're looking for every opportunity to avoid. Also, if they begin to talk about increased use of alcohol, where used to do they had a glass of wine once a week, now they're having several every day, or drug use, like they're wanting things to keep them up and they're wanting things to calm them down. Lastly, if you notice that they have no interest in things that they typically enjoy, our organizations should really look for opportunities to provide additional training to all of our staff around recognizing basic signs of mental health issues and suicide ideation. Just simply being comfortable with asking the question, if I am concerned about you, have you had thoughts of suicide or killing yourself or harming yourself? Yes, it sounds uncomfortable, but it can save someone's life. And that's what I've really had to push with people, is not being afraid to ask the question. What is it going to hurt? So if you or someone know that someone is struggling with very real concerns, I always encourage people to utilize that suicide hotline for support and resources, which is 1-800-273-TALK. 1-800-273-TALK. And because the person needs to talk and they need someone to listen. So in times like this, it's just really important to emphasize that they're not alone, and you want to connect them. Don't feel like you have to carry the burden of it. Get them the help that they need.
Great. Again, talking, key point here, as well as listening, key points in today's session. So I'm going to turn this one over to Leslie. So Leslie, for years I've talked about, as healthcare professionals, the whole idea about patient well-being. And now we're learning that our healthcare institutions better start thinking about workforce well-being. So what can organizations do to really shift the focus to include the workforce well-being and being able to meet the workforce needs?
Well, do we have another 3 hours for this panel? Sorry. So this is such a great question, because 100% spot on. Well-being and burnout, this is all a workplace phenomenon, right? I think we've hit on that. But so much, right, that we've been studying burnout for so long. We know this now. The World Health Organization changed burnout from a medical diagnosis to a workplace phenomenon. It's not your problem. Burnout's not your issue. It's a workplace issue. The National Academy of Medicine has a whole action collaborative on looking at burnout and well-being. And in 2019, they put out a big recommendation for healthcare organizations, 6 recommendations for what healthcare organizations can do. So it's very much things that organizations can go out and do, not you, the individual. So it's things like, first of all, we need to start, as Felicia said, talking about it. We need to measure it and understand what's going on in our workforce, right? We shouldn't just start throwing things at them without understanding. Are they really burned out? Are they doing well? Where are they having issues, right? And then we need to look at the work environment. So how is our work environment doing, and where can we grow it? The work environment's not this magical thing. We know a lot about the work environment. We know there's things like workload and staffing. We know there's collaboration. We know that there's decision making. So what area are we struggling in our work environment, and where can we put our efforts to improve it? We know our learning environment. So our residencies, our preceptorships, these are huge strains on us that cause burnout. So essentially, we're looking at all these root causes of burnout and where can we go to fix it. And then this last one that I'm going to talk about should come as no huge surprise, but our documentation and our administrative burdens. So whoever's out there tackling these issues, I give you huge credit, and please keep working on it, because these are huge sources of burnout. But when we look at all these issues, coupled with like our secondary traumatic stress and other things around our communication that cause us burnout and fatigue, these are where our healthcare environments, our workforce, our work environment organizations can come in and support. It's not just the mindfulness, it's not just the personal resilience building activities. We've got to get in this with our leadership and with our culture to really tackle the issue.
Great. Peter, I'm going to ask you the same question. What can we do to facilitate workforce well-being?
Yeah, and this is a place that we've really kind of by necessity have grown into in the last year. And so one of the things that we, of course, the central, in addition to my background as an orthopedic surgeon, I also have a PhD in mind-body medicine, largely with the focus on chronic stress and its contribution, adverse contributions to our health and well-being, and how to utilize that to then support well-being. So as we started seeing this play out, some of our clinical partners came forth. One in particular, Hoag in Orange County in California, came forward and said, okay, we know you have this central focus on chronic stress. What can we do to help our nurses, to help our staff? One of the things that we found through that effort is that just offering something of value to people, saying, hey, we know you all are stressed. We know that this is an overwhelming situation. We, as an employer, we want to help you. We want to offer you something that you can use. I think just showing care and concern in that way is powerful. But what we found is we kind of had this idea, well, we'll give people something they can do. In our company, we do virtual reality experiences. So we can put somebody in a headset, they can, during a break or whatever. Turns out nobody wanted to do that because, number one, I think there was some stigma associated with that. Like, I'm going to show that I need help by going and doing this. And so what we found was having the offering, simply having a flyer that had a QR code. They were able then to walk by as they're walking down the hall or on their break, and just sort of swipe the QR code on their phone, which would then lead to a headset being sent to their home, right? They would do a little bit of registering on their phone, a few demographic things, where is it being sent? And then boom, a headset shows up at their house. They're able to do it at home. And so what we found was tremendous engagement when that was offered in that way. So sometimes it's meeting the needs of the people is meeting the needs for them to not necessarily want to engage in that or to admit to that or talk openly about that at work. It's offering them another way to do that. So I think having, and we've heard this a bunch in this discussion today, and I'm certain that we'll hear it again, having new and novel and ways of addressing burnout, because everybody, we're all individuals. So we all have our own ways that we're willing to or not willing to engage with that, our own tolerances for who we're talking to about it or not talking to about it. And I think having a variety of ways for individuals to access resources, so the systems can provide resources for people, but then also offering some choice and some variability and some individuality in how people actually engage with those resources.
Thank you. So Felicia, you deal with this all the time with social work. So I'm going to ask you, what should healthcare systems be doing to get to the point of workforce well-being? And I'm going to lead it into the next question about work-life balance. And, I think it should be more work-life integration because it's hard to get a complete balance. But Felicia, what can healthcare systems do to really get that workforce well-being? And then what can the organizations do to help support that work-life integration?
Absolutely. Thank you. Leslie and Peter share so much, but as with most things, I think that earnest transformation must happen from the inside out. So in order to provide the highest quality outcomes for our patients, we must ensure that we are supporting our staff and supporting our workforce. And so we can do that in so many ways. There are several recommendations that have already been given. But I think having intentional wellness programs and having several platforms to provide that is key. People are really more open to more virtual programs than ever before. They need to be easily accessible and affordable, right? It doesn't need to be anything that takes an hour, 5 minutes, 10 minutes. And also incorporate wellness as a part of your meetings. When you're having to have huddles. I was recently on a virtual or regional meeting, and the business leader of a group of 40 clinical managers, she actually opened up the meeting doing a 5-minute mindfulness. Now, usually they would have asked me to do that, but I was so grateful to be able to see her do it because that's the way she was leading by example. And so it's good to be able to see other disciplines reflecting that. And then also, we've actually just started amongst the social workers and dietitians a rally where we're being competitive, with our steps and our miles. Now, I'm not like in the top 10, But at least, I'm leading by example to say, listen, even in the midst of my hectic work, I'm taking the time. And so I want you to know it's important for you to do that as well, because the opposite of illness is wellness. We got to change the I to a we. So how can we collectively begin to do some of these things together? And I think that's a part of incorporating that work-life balance. We can do that, through many interpersonal ways. But in my line of work, what I have seen most noticeable impact on well-being in a collective workplace is that when we just foster an opportunity for people to be able to share their emotions. And then at a visual level, encouraging them to get involved with conferences like this, where we can get people off their own island, get them out of that place of isolation, finding new ways for them to be able to engage very easy. And we must implement and encourage people to implement non-negotiables. And when I talk about work-life balance, people think that requires another task. It's not an indulgence, it's a discipline. So you got to have some non-negotiables like, eating, sleep, exercise, spending time with your family, the simple things that doesn't really take a lot from you, doesn't take a lot of money, but that's a time that you spend that you'll never be able to get that back. And so when you understand what you value and helping people prioritize their priorities, I think that's when we begin to see the difference, and helping people move from that fear zone to that learning zone and understanding what they've learned from the experiences. What have they learned that's really important to them? And how can we help support what's important to you as well?
That's great. I love that. Change the I to the we. I love that. So Leslie, same question to you. We talk about this whole idea of work-life balance. It's really somewhat unobtainable. So a lot of people are shifting the conversation to work-life integration. So, you're a part of a huge healthcare system. What does your organization do to help with that work-life integration?
Yeah, I like that. We too. And I think I have 2 young kids, so I gave up the idea of balance a long time ago. We talk about that a lot in the mommy realm. There's no such thing as balance, but you really, you've got the point there that we sometimes so much focus on the negative, right? And I think clinicians are especially guilty of this. It's like, well, I got 4 hours of sleep last night. Well, I got 3 hours of sleep last night. And as Peter was saying, like, that toughness gets us nowhere, right? We need to flip the switch on this and say, who's going to role model well-being better? So I love that Felicia's talking about the activities that we do. And so I shared before we started this panel discussion, I was talking and sharing about how my company just switched all of our technology platforms. We're switching over to Google. And I have such an amazing team. We support each other through this, and we knew it was going to be tough. And so we all agreed we're going to clear our calendars, right? And we're not going to have meetings as we're all going through this transition and we're learning this new technology. And that's the kind of thing we do to support each other with this integration. We knew that it was going to be stressful. And so I'm having a couple meetings with other people, and they're saying, oh, I have to go home and clear out my 8,000 emails that came over. And they're starting that negative talk, and they're starting that, this was a bad transition and it's going to be so negative. And I got to say, I have a great team, and I had, all this time because my team cleared our calendars. And so it's flipping that switch and saying, this was a really okay thing because we had great teamwork and support, or it was role modeling that it was tough, but it went okay. And so we don't always do that because we try to be hardy. And, just as Felicia was saying, role modeling the mindfulness, we do reflections in our company. And so it may seem like little things as we integrate well-being and we integrate that balance. We don't hear managers walking out on the floor at 5 o'clock waving to their staff saying, okay, I'm leaving now because I'm going to go meet, someone for dinner, or I'm going to go catch my kid at soccer practice, or we don't see them coming in at 8:30 saying, I had this thing in the morning. We very much get into this culture where we try to outdo each other with not well-being. And so I would really love to see that integration come as we're role modeling it, we're talking about it, but meeting it with, we're still providing the patient care, we're still doing what we need. And that's going to take effort from everyone. So it's a long-term goal, but I think it comes from the role modeling, it comes from the balance and the culture, and it works out to where we have to do it with support from each other.
Absolutely agree. So Peter, I'm going to ask you the same question.
Yeah.
I know that the organization you're working with is doing some new innovative things around work-life balance and integration. What are your thoughts?
Yeah, and I love the term integration, because it always felt like when we talked about work-life balance, it's like I have to figure out how to balance the me I am at work, or the experience I have at work, with the me I am at home, or the experience I have at home. And really, it's when I leave my house, I'm still me. When I go into the hospital, I'm still me, and I'm bringing all my preconceived notions and my past trauma and all my skillful or unskillful ways of dealing with emotion with me into the job. So it really is how do we identify the needs of the individual, and then provide them, and I think, again, practical and simple, right? How do we give people knowledge, skills, and practices they can use to support their own well-being? And and sometimes we say, well, what's the difference between a skill and a practice? Well, a practice I see as something you do repeatedly over and over again, like a mindfulness practice or something like that, where you're sort of committed to something long-term that helps sort of change the way your brain functions in certain situations. And skills is, what can I do in those moments where I am feeling overwhelmed, when things are tight, when I am feeling very triggered, and then how do I bring myself back down, regulate emotion, or work with difficult thoughts or whatever in the moment. And so I really think that, and then again, those skills then translate wherever you are, because we're meeting you as an individual, not as a physician or a social worker or a nurse or whatever it might be. We're meeting you as, as Pete, as Leslie, as Felicia, as Ann. So it's like, we're going to meet you where you are in life, regardless of your context, and then give you what you need to really help you cope or overcome or regulate in the moment, in whatever way is appropriate. And do that. And of course, then I'm going to pound this point, do that at scale, which is kind of the new frontier in this whole burgeoning field of digital health and digital therapeutics. Is how do we do what's needed? How do we offer what's needed to people in those ways to give them real tools and skills, but then to do it at the scale that's needed so that people aren't falling through the cracks and winding up in irreversible burnout or suicidality or addiction or all these things that we've sort of touched on.
Absolutely agree with everything you said. And I wanted to talk about our employee assistance programs that have been in place for a long time. And now we see over the last, a little over a year now, we're looking at them differently. Is there something in the employee assistance programs that we offer that we should change or add? What do you think?
So again, I can speak from experience, and I can speak from what we're seeing in the market today. So a lot of times, again, it feels like, to me, I'll just speak personally, to me, a lot of times the employee assistance programs often felt like something else I had to do, right? It was like I had to go talk to somebody or find the office or reach out and send an email and say, hey, I need this assistance. And then it would be in the organization I work for would be, well, come to this office and, talk to this person or fill out this form. And it's like, man, I've got, when I leave when my time at the hospital is done, I got to get home. I got kids to get to practice. I got, other things to do. And so it kind of becomes another thing to sort of think about. So how do we, again, meet people where they are with something that's really going to help them? I think that to me is so critical, is how, and I think through COVID, it sounds like, and what I'm hearing is like, we're really having to rethink how we reach out to people and offer resources to people, because the whole system is overwhelmed, including people, seeking and offering assistance. What we are seeing today is, again, through this pilot we ran for nurses with a stress program offered through a virtual reality experience, was that when it was offered, we had overwhelming numbers of people. We offered it to 50, 33 said yes. So we offered it to 50 people, 33 said yes. So 60% of people took something that was offered through an employee assistance program. That's a pretty good number for most things offered through an employee assistance program, in my experience. You guys may have other data. of the ones that actually gave us feedback, so then we had some different metrics we sent them to ask questions to get feedback. Of the ones that gave us feedback, all but one, so whatever that number is, 90% or so of people, when we said, is this something that you would like to see offered as a regular part of employee assistance, they said yes. And I think it's nice because, again, they were able to do it on their own terms. There wasn't a heavy lift. It was scan a QR code, put in your name, your address, a couple things that we needed to get, and then boom, it shows up, and now you have something you can do in the comfort of your own home to build skill wherever you are. So I think with everything in life, if you make it easier on people, they're more likely to engage with it. If it's meaningful and provides them something they believe is going to help them with minimal lift on their part, then I think that's the simplest way to serve people and to serve them at the levels that we're talking about serving them today.
Absolutely agree with what you said. Since we're getting close to our time, I'm gonna ask the last question. What are the top 3 things healthcare systems can do to support their workforce and demonstrate to the workforce that they are valued? And we're going to start with Leslie.
Absolutely. So when I think about, what can my healthcare system do for our workforce, especially now after COVID? Number one, we've got to start talking about it. We've got to start talking about well-being. We've got to start talking about it so we can reduce stigma. The goal here is to reduce stigma and start talking about it more. And I think we're getting there. I think number 2, we've got to create that culture of well-being, and that means role modeling it and embedding it. So those practices, those skills that we were talking about has to come from the leadership. It has to work its way into our staff and our employees, and it has to be through role modeling it and embedding it into the work that we do. And then number 3, we need to resource it. We need to provide the good quality activities, resources, and actions that allow us to support our staff in the ways that we're talking about it and that we're role modeling it and embedding it.
Great. I'm going to go back to Peter. Peter, what are the top 3 things that a healthcare system can do to really support their workforce and show them they're valued?
Yeah, I think number 1 is, as we've said repeatedly today, is to normalize their experience. It's okay to feel these things. We're all feeling it. It's normal. You're not a failure for feeling these things. Normalize the experience. 2 is to offer them real assistance in ways that are meet them at the human level. Not just we're a company, so we have to offer these things to meet X, Y, and Z criteria, which is sometimes how it felt in the hospital. Like, oh, we have these things and you can come get it. But really meeting people where they are and saying, here, we know that you're having problems. Here's some things that you can do. And then I think, third is then when you're offering those things, is offering them things that are going to translate to their entire experience, as we talked about, to that integrated experience of, yeah, you're having these problems at work, but it's not like you have these emotions and this sense of burnout and overwhelm when you're in the hospital. Then when you leave out of here and you drive in your car and you get out a couple blocks away, it suddenly goes away. You're carrying that in the home, and then your family is affected. Your kids may be affected. Everything you do is affected. Your sleep cycles are affected. Your overall health can be affected. So offering them things that say, look, these are real solutions that are going to help you on all the levels. We're not just paying attention to workplace burnout, which is highly important, but we're also offering this to you in the sense that we want to improve your life. And I think that shows real commitment from an employer to an employee to say, yeah, I'm going to feel good about working for that place who I really feel like cares about me as an individual and not just as someone they're trying to retain on staff or because it feels like they're supposed to.
Thank you. All right, Felicia, it's time for you to bring it on home. What are the top 3 things that healthcare organizations can do to support their workforce and instill that feeling of value in them?
Yes, I think, one of the top things is to validate burnout on all levels of care. Secondly, ensure that resources and staffing are supported. I know that we found various ways to do that because we realize our staff wear several hats in and outside of work, and it's really about that integration. So we offer several things like child care stipends, elder care stipends. We had emergency pay in place to be able to supplement some of the concerns that they have at home. So making sure they have those resources, not only just financially, but also providing that those emotional mental resources as well. And then I know this sounds really simple, but it's just showing appreciation, like saying you did a great job, and sharing those successful team stories where they can see where by working together, by collaborating, this is how we're showing value. You know, taking the front line, bringing their pictures, their stories to the front, and looking at ways to show the connectedness. And that's one of the reasons that I'm wearing blue today. Is just this is me representing my frontline staff, you know, of what they're doing and saying, hey, I represent you. I care about you, and this is my way of continually thinking about you and just showing that I'm grateful. And I think reminding people how to show they are grateful for others and showing that appreciation in the simple ways, not just with a pizza, but just simple ways by just saying thank you. Those are very, very long way.
Well, thank you for that. And I'm going to say thank you to our panelists, Dr. Peter Buecker, Leslie Kelly, and Felicia Speed for being on this really important panel. And I just want to say a big thank you to MedCity. MedCity took the time to invest in this topic around tackling burnout and mental health of our frontline workers. And that's so important to make sure that our frontline workers feel valued and supported, because we're talking about people. And when we think about the idea of wellness as healthcare organizations, we need to shift from just thinking about wellness of our patients to wellness of the people that work within our institution. Because without a workforce, a healthy workforce, you're not going to have an institution. So I just want to say thank you to our panelists, to MedCity. Thank you very much.
Thank you.
What a compelling discussion on addressing the needs of our healthcare workers. I'd like to thank Anne, Peter, Leslie, and Felicia for taking part in this important panel discussion. And thank you for tuning in.